Thank you very much. I'm very pleased to be here and to give you this presentation on how to get the best practice recognition for your FLS.
Great. Kristina, if you can click, okay, wonderful. We can now see your screen.
So, and I'm very happy that we are collaborating with the NBHA on this matter, since it's really important with secondary fracture prevention. The learning. IOF has initiated Capture the Fracture, and it's a program to improve secondary fracture prevention in a worldwide perspective. The learning objectives of this webinar is how to apply the best practice recognition, how to fill out the FLS questionnaire, how to use the best practice framework to set up a model, model that is effective FLS, to understand the key principles of how to implement an FLS, and build awareness of the tools available to you on Capture the Fracture website. And as you will understand, it's complementary what the NBHA is doing and what IOF is doing. Fracture Liaison Services were coined in 1999 in Glasgow, which you who are attending this seminar may be well aware of. And it actually is a proven solution for secondary preventive care. It's effective, and it's also cost-saving, not just cost-effective, but cost-saving. The role of an FLS is to identify fracture patients, investigate osteoporosis risk factors, initiate treatment and fall prevention, and ensure adherence to the treatment. And as you can see on this slide, there are lots of stakeholders involved in managing fracture patients in order to give the best secondary preventions. But the key person when we discuss FLS is the fracture liaison coordinator. This is just a cartoon of the service structure for Fracture Liaison Service, where we recognize that the patient presents with a fracture. It's identified either at an emergency department or an X-ray department, and it will then be handled either as orthopedic or emergency departments for trauma. And then the patients will be either managed as inpatients or at outpatients. These systems varies throughout the world and throughout where you are. And of course, closed systems versus open system, there will be some diversity. The next person is then the key, when the fracture is acute fracture management is finished, is the Fracture Liaison Service that identify the fracture patients and assess them, and then decide on treatment, assess false risk, exercise programs, education programs, and it's a comprehensive communication of the management plan, commonly to a general practitioner, but again, this may vary with the system. Capture the Fracture was initiated by the Fracture Working Group already around 2010, and then after continuing to work with it, it became the flagship program of the International Osteoporosis Foundation, IOF, and launched in 2012 under the heading Capture the Fracture. The key aims is to be the global voice, to drive national and international policy, to ensure quality, and to provide support for FLS implementation to get them started and to improving them and make them sustainable. There are many steps into coming to a point where you actually can implement a program, but applying the best practice recognition program is a good way of starting the process, and all of the tools are available for this. But firstly, it needs political prioritization, it needs to get funded, and then to get started, and then to improve the sustainability. And the first three steps, actually, it's almost always essential to have a champion. Champions can't be ever evaluated because they are needed everywhere to get to the stage where they actually are sustainable and possible to improve. Why do we need to do this? I think that all of you who are attending this webinar knows why it's important. We know that we have a high incidence of fragility fractures, and we know that they also are going to increase over the coming 30 to 40 years because of aging populations. We know that there is a care gap. Only 80% of fracture patients or 80% of fracture patients are not screened or treated, and actually the ones who are treated are down to 10 to 15% in many countries. And we also know that this is a global health and an economic burden in most of these countries. And it's mainly through the direct cost for the first part, but many of the fractures also have high indirect cost because the patients are not going back to their full capacity after a fracture, but need social help or can't go back to work. We also know that closing the care gap is difficult. The steps you see in the circle we need are the basic steps in a fracture liaison service: identifying the patients at risk, systematic investigation and risk assessment, and I like to highlight the point systematic, because when it's left to random, we are losing many patients and we are not seeing all those who actually are in need of care. Then the next step is appropriate treatment and initiation. And the final step is the ongoing treatment and fracture monitoring. And here we also again see many difficulties today where patients are not continuing to take their medication even if they've had a prescription. So in order to work on this, we have the dedicated fracture liaison service person, the coordinator. We know that if this is done very well, we get lower refracture rates, we get probably fewer secondary care admissions, and we get fewer care home admissions. All of this is healthcare savings. So the logic tells us that we should be doing this. Nevertheless, it is not done universally and rather poorly in most countries, both in the Western Hemisphere and in other places. Then we can ask, is a fracture liaison service automatically effective? Well, they may not be, but there are ways to improve them. It is to set clear criteria and standards, to audit the services against them, to provide feedback, and then to inform effective care. Much of this has been developed further in the UK. Since Glasgow was the first place, many other sites in the UK have been working very thoroughly to obtain this, and they have a much better coverage than most other countries currently. Regardless, there are at least 4 challenges to manage the care gap. When it comes to identification, we know that we can possibly find the majority of fracture patients, but it seems easier to say than to do. Hip fracture patients may be difficult because of other comorbidities, such as dementia. We also have other inpatients. They may be placed at various wards, at least in Europe, so you may not immediately find them because of lack of beds. The outpatients may be managed in many different clinics, and smaller fractures may be directly outsourced to other open clinics. And vertebral fractures may be quite difficult to identify, since we know that at least 2/3 are not seeking help immediately, but may be only found at random later. And radiologists are rarely then reporting new vertebral fractures. We also have problems when it comes to investigation, because it's many patients, at least times 3,000. It all depends on where you are and where your service is. So it may be very many patients, and the logistics around that may be quite difficult. You also have to have access to DEXA, and this is not universal and easy to get at some places. And it also should be convenient for the patients or minimally disruptive for them so that they'll actually come to the investigation. The next one is initiation. We of course have to match the treatment or the intervention to the patient, and that may also be a challenge in this respect. And then we come to the last part, the monitor part, where adherence is known to be a problem, particularly for first-line treatments such as bisphosphonates. We also have side effects. We have refracture that may occur, and we have falls. Particularly falls is very difficult to monitor in most systems, and there are no registers for falls, and it's then difficult for us to know exactly if our interventions have been effective. The purpose of the best practice framework was to set standards for an FLS, give guidance, and benchmark and fine-tuning. That was the whole reason for trying to summarize all that was known at the time when we started out with the best practice framework. After quite a lot of work, we came down with 5 domains and 13 standards. We have hip fracture patients, inpatients, outpatients, vertebral fracture patients, and an organizational level. The best practice framework is available on their website and easy to download. The 13 best practice framework criteria and standards are these, and I will go through them with you. It starts out by the definition for the first one. It's the fracture patients are identified and enable delivery of healthcare, of secondary fracture prevention. And as you see, we have the standard, and then we have various levels, in this case bronze, silver, and gold. And here you can see that whether we are able to track, or if they are tracked, or if that you have an independent ability to review. And this really comes back to the final standard about databases and organizational structure. Standard number 2 is identified patients are assessed for future fracture risk, and it's then understanding what proportion of actual fracture patients are you able to capture within your FLS. And this means that you have to know how many fracture patients that are actually there. Sounds easy, but it's quite more complicated than it seemed to actually know your baseline number of fractures, and we can see that in quite a few of the systems. So that means that it's not just finding those who you see, you also need to know the proportion that are actually assessed. And this will provide you on the bronze, silver, or gold level, depending, for example, if more than 90% are assessed. We also know that it's very important that this is done in a timely fashion when the patients still connect the fracture to initiation of treatment and investigation. So the post-fracture timing is one of the standards, and if it's done within 8 weeks, it's considered a gold standard. And it gives sufficient amount of time for the majority of patients to have managed the acute time for the fracture and then be able to return to the fracture clinic or to the FLS clinic, wherever the first assessment takes place. Standard number 4 is system to identify vertebral fractures. We regard this as one of the most ambitious ones, because the gold standard here would be that a radiologist at any type of X-ray identifies vertebral fractures and sends a notice to the FLS. Only very few places have this running at the moment, but many are working to implement it. This would mean that a radiologist notices it on X-rays for the pulmonary X-rays or gastrointestinal X-rays, but also on regular spine X-rays taken for other reasons. The other levels is whether it's done routinely or if it's the fracture patients are known. Standard number 5 is secondary prevention assessment is consistent with guidelines. And this is in here because we really think it's important that guidelines are in place and guidelines are followed and guidelines are commonly developed by experts. And whatever is done at a specific site should of course be in line with these, since they're all evidence-based. Standard 6 is patients screened for underlying causes of low BMD. And this is, of course, secondary causes of fractures and what proportion are assessed. The next one is the fourth risk assessment, if it's evaluated and the patients are sent for prevention when appropriate. The 8th standard is that practitioners are screened and referred for existing lifestyle changes to reduce fractures. We know that reducing the risk factors that we already are aware of is one of the ways that sometimes has to be the only way that we do particularly for some elderly patients where pharmacological treatment is not feasible, for example, because of poor kidney function. Nevertheless, quite a lot can be done. It's one of those things that, however, is difficult to track and follow afterwards in most systems. And it's difficult to evaluate effectiveness, although it's important that it's done. Standard number 9 means that patients not on treatment at the time of fracture are initiated on osteoporosis treatment. And this is a relatively simple one where we see the proportion, and that medication should of course be in line with the guidelines. So whether what is recommended in the specific country for what should be used as a first line or second line therapy depending on the patient's needs. Standard number 10, patients already on treatment should undergo reassessment of medication. And we all see today that more and more patients have at one time or other been on particularly a bisphosphonate, and they should then be reassessed, particularly if they have stopped taking the medication, but also if they take it because now they've had a fracture, so we need to review what is the best treatment plan for the future. Standard number 11 is the FLS management plan is communicated. And most FLS can't keep all the patients there for the continuation of their treatment, but they need to be managed by their ordinary doctor, and in most places this is a general practitioner, but of course this can vary depending on local circumstances. Standard number 12 is a protocol for long-term follow-up and for patient adherence, and this is a dichotomous standard where whether you can do it long-term or only for a limited time, and how well it can be done. And the standard number 13 is fragility fractures are recorded in a database. And today, a large number of countries have databases for hip fractures that are national. However, all other fragility fractures are often lost, although it's important to be able to track what you've been doing when you initiate a new service so that we know that it's cost effective and it's also effective for the patients in terms of fewer fractures. Most of the payers or stakeholders need to see that that there is an effect of a service that's initiated and not regarded as a standard before an FLS was initiated. So with this, this gives you a background to the best practice framework, which actually contains all the elements that are necessary for an FLS and how to build it successfully. Now the question is how to get MAP and to be participating in the Capture the Fracture. Because Capture the Fracture and the best practice frameworks are tied together, and it's a way of showing what you have done and participate into improving what you are doing. The process starts with submitting an online application. and then get mapped, get a score, and get recognized. So we start with the first step. The FLS submits an online questionnaire, and I will go through the questionnaire in more detail. The questionnaire has recently been revised, so this is the second version of it, because we realized that some of the questions we had were too difficult. So we've also developed a tool that helps you and explain all the questions that are there. But we've also added questions that we found were important for us to know to further better understand exactly what is the service could provide at each site. The second step is that the FLS was marked in green on the map while being reviewed. So all the green flags or stars you see here are those who are in the program, but they're not yet evaluated. Or some of them may not have sent in their full application yet either. And then the FLS is scored and it's recognized on the map. In this case, you can see that's a site in Iowa, Des Moines, who has got a 4.2 score and a gold star on the map. And you can see the maps that are available at this time in the US. And this is again, when you expand or click on the star, you can go get more information on how they're working, how big the site is, what the population it is serving, and how many fractures they're handling. And this is provided so that people who are close by or at other distances but live in similar system can contact you and get ideas on how to do themselves when they start up or want to improve their own service. The scoring domains I briefly showed you before is the hip fracture patients, the non-hip inpatients, the tubular fracture patients, outpatients, and then the organizational levels. And from a service perspective, we think that doing this scoring and trying to thoroughly assess each site that drives improvement. Of course, someone who has got a 5.0 will wish to maintain it when it's reviewed, and those who are lower will try to reach there. And then it's important to recognize excellence, and it also turns out that when you have been scored, you're more likely to get funding to improve your service. From the patient perspective, which is even more important, is that the patient can also look at this page and see, will I receive effective secondary prevention if I have a fracture where I live? And I think this is something that we're constantly struggling with, that our patients sooner or later will demand that we also assess them for recurrence of a fracture, like we do in most other conditions today. We wouldn't let a cardiac infarction patients go without treatment, or a breast cancer patient. But with fracture patients, we tend to do, although, so it will be more a demand from the patients that will push this forward. As of yet, we have 174 fracture liaison services registered on the map, and you can see that they are all over the globe, which is quite interesting. This means that the standards meet the criteria that are necessary, the building blocks that are necessary for starting a fracture liaison service anywhere in the world. It's the basic building stones that are similar, although the local circumstances may vary and the logistics will vary depending on where you are. And I think this is very important when you argue for having a fracture liaison service, that it is, and you can also use the information that is on the site and in the literature to apply it to your own site. Particularly important in order to obtain funding. Now I will go through some of the steps to complete the questionnaire. All of it's on the website, and we've also added new information to help answering the questions. And this may not be so applicable to the US because you speak English, but to countries that are not in English speaking, some of the words may be difficult to interpret, although they seem very easy. The first part of this is demographics. It's about the hospital, where it is, the population, what type of hospital, and where the site is. The next part is the user information, so that we know who's in charge of the FLS, and with the lead clinician and the coordinator. We also try to understand the size of the FLS by understanding how many persons are involved in the FLS service. For example, physicians, nurses, physiotherapists, occupational therapists, administrators, etc. And all of those are equally important in being successful, but it also provides the information on how FLSs in general are developed. The next is about patient identification. Which ones are identified, and we clearly acknowledge that when you start up, you may not be able to address all types of fractures. And generally speaking, it's much better to start with one or two types of fractures, or inpatients or outpatients, because it's easier to start small and then let the system grow, rather than to do a too big undertaking and then not being able to continue it. We also ask about the post-fracture assessment, where the patient, who assessed the patients, where they are assessed, what facilities there is for DEXA measurements, if it's done, other types of investigation, and continuously for the patient identification, the proportion of patients that are identified. For the patient evaluation, we also look at the number that were there before, and inpatients versus outpatients. The timing is essential, as we said, and this is of course an estimate of the proportion of patients who are estimated within the specific time frame. And the questionnaire here gives you an idea of what to register when you start up on FLS, that it may be important to know what time how long after a fracture it is before you do the investigation. Vertebral fractures, similar questions. It's also to understand the service better, and sometimes when there is something we don't understand, we always come back to a site to complete and to understand better how the service is working before there is a scoring. Assessment guidelines, whether they are available, to what level, but also what risk calculators are used, if any is used. For example, fracture, Q fracture, Garvin, or none, or others, or if they're complemented with other questions. Particularly FRAX needs the addition of a false assessment or false history. Secondary causes, similar to it, some of these questions are added to get a better perspective in general of what is done on secondary prevention. For example, what types of standard blood tests are done. False prevention service, we recognize that these are growing, and sometimes they are not within the FLS, but they have been in place before. But it's similarly equally important to assess falls and to address falls as to address bone quality with the pharmacological treatment. And the next question is lifestyle risk factor assessment. As we know, for example, smoking is an important risk factor, and anti-smoke programs should be in place for these patients. Medication initiation, I don't need to go into further. Similarly, medication review or the communication strategy. And here we have found that some of the patient organizations are quite active in also for the patients to know exactly what type of information they would like to have, and what type of information we also report to the other doctors, and how we have covered all the areas that are essential in fracture prevention. such as whether BMD testing is done, whether false risk factors are assessed, risk factor scores, follow-up plan, etc. Long-term management is these are the questions for this, and also for then for the databases, whether they are available or not. The final step is to submit the questionnaire online, and then it's managed through the IOF office and through those who are scoring the questionnaire. We have developed also a number of tools to help implement FLS. Best practice framework is actually a tool in itself. So then we have also slide kits, toolkits, webinars, and mentors program. And this is quite similar to what the NBHA has, and we are collaborating on those. We started out by scientific publications, and you may know if you search for fracture liaison service or secondary prevention that there is a growing number of papers showing all the efforts that are made to improve patients' care when it comes to refracture rates. One of them that IOF is doing is a mentorship program where we will be able to do one-day trips to at an FLS Champions institution and customized support. We'll also have one-day workshops for participants with international and local experts. And this is for many, particularly countries who are not as developed in this area as, for example, some European countries. We also are developing a patient charter, which comes back to the fact that the patients can ask, will I get appropriate secondary prevention after my fracture? We think that a patient charter, where the patients actually can demand that they are assessed for future fracture risk, is one of those things that will drive change in the future. And the slide kits and toolkits are then also available. And the best practice framework is now being translated. Currently it's available in 10 different languages, 5 of the 10 most spoken languages in the world. And we're also translating the questionnaires, because it turns out that it's, as I said, English may be a fantastic language, but it's sometimes, even if you speak it or read it, when filling out the questionnaire and understanding this, it's a great advantage to have it in your own language. In the webpage, you can also find the various national toolkits. We have used the webpage to allow all countries to be able to submit information that they have. And this is particularly important because we think the FLS will rely on the fact that people are sharing information and supporting each other. Generally speaking, when someone has started and you can visit, or you can come there, or you can read about what they're doing, it gives you a greater possibility to initiate your own FLS and to also have it assessed according to what, to start it and have it assessed according to what we know is those cornerstones that are essentials to have a best practice. Here we're showing what's available from the US, and here you can see the bone health, the National Bone Health Alliance is also on this website. For example, here we have also Australia. And another country, New Zealand, has just recently passed a national priority for secondary prevention of osteoporotic fractures. So we can see that things are moving on. This is also another view from the website where you can actually go in and look at the map and see what everyone else is doing and get their information. And this is the steering committee for the Capture the Fracture, and who has worked with it for a long time to develop all the tools and things that are available for Capture the Fracture and the best practice framework. With that, I'd like to say thank you to the CTF sponsors, but I also like to say thank you to all of you who've been listening, and I'm happy to take any questions. And I also, first of all, would like to say that I hope that all of you are able to join Capture the Fracture to get a star on the map, because every star is needed for also to show how important it is with secondary fracture preventions. We know that these are the patients with the highest risk, and if we don't capture those or can show to our politicians, who are decision makers, our payers, how essential this is and that it's occurring all around the globe, it's more difficult for everyone. So I'd like to encourage you to also sign up to Capture the Fracture, regardless of where you're working and how you're working.
Great.
With this, well, I'm happy to take questions.
Wonderful. Before we start going through the questions, I just want to remind everyone that you can enter your questions in on the GoToWebinar control panel. I also wanted to mention that in the handout section, we do have 2 handouts that are available for download for this webinar as well. Great. First question is, what is the most difficult part of an FLS?
I would say there are 2 difficult parts. The first one is to get sufficient resources to start it. You have to have the champion, but you also have to have an FLS coordinator or a person that's coordinating so you can get a start. And because when you have a start, you can start showing what you're doing, and when you can show what you do, it's more likely to continue. The second part in an FLS, in my experience, is the identification of the patients to make sure that this is done. Because since many systems don't have a rapid turnaround with diagnostic coding or the way to identify, it may take some time before the patients are found. And it's a tedious work to identify through the various ledgers or surgical ledgers and outpatient ledgers. And that's where it becomes somewhat difficult. And the next difficult part in settings where you have closed system and rely on primary care is the referral to primary care, to have them be familiar with and comfortable with treating osteoporosis patients.
Great, thank you. Before I go on to the next question, I just wanted to let everyone know, as I mentioned at the beginning of the webinar, that the video of the webinar will be available and posted on the NBHA site as well as the NBHA YouTube channel, and that we will be able to make slides available as well. Okay, the next question is, what is the best way to get funding? Are there many examples of business cases available?
There are a number of business cases available, and on the tools section, there are quite extensive write-ups on how you present your business case. It's generic to many, and one of the persons who worked a lot with this is Paul Mitchell, and I think this is particularly useful in the US. In some closed system business case, write-ups doesn't work as well, but in the US I think it's very valuable. And I think that, so those templates are there, and I think that should be, there's no need to reinvent anything because the data is there in the business case saying that what the size of the problem and etc. and what the gains are if you do this properly, systematically and structured.
Great. I would also add, this is David Lee. We just released a few weeks ago a FLS return on investment calculator. So if you haven't taken a look at that yet, go to the Fracture Prevention Central website and you can download it. There are links to the webinar that we hosted to announce it, and also a specific video that shows just the walkthrough of the user input screens that I think is a real great new addition to making that business case in the US.
Great. Here is the next question that we have. It's a long one, so I'm going to... Okay, we are currently doing an FLS pilot and are having difficulty in getting patients back in after fracture for bone health assessment within 12 weeks. They are elderly and overwhelmed with a fracture, rehab, PT, etc. Do you have any suggestions?
I think that information to all other professionals is important here, so that also physiotherapists and everyone can encourage the patients, because it's quite well known that the older patients think it's more difficult and less important. So, and we also know, at least here, sometimes use the fact that some of the elderly patients, we know that they have osteoporosis, so already at the first assessment while they're at the hospital, we can say that this patient is eligible for treatment, and particularly if we can use zoledronic acid, for example, as a 1-year treatment, it's easier for the elderly patients. So it does help, and it may not be necessary to do a very extensive investigation on some of the patients. And that's what's currently occurring, at least in Sweden, at some of the orthopedic units for the elderly, as long as they have sufficient kidney function.
Great. Our next question is, do you need 1 year of benchmark data at your agency to use a fracture investment calculator?
I can't say about the fracture calculator because I'm not working with one, but generally, overall, you need to have 1 year data to know exactly how many fractures you have, so you can follow up on the number of fractures. The problem really is to know how many fractures you save, and you need much longer term to be able to say that. You use process measures for the in-between times. For example, how many patients have been put on a drug, or DEXA measurements, but those are actually process measurements or process indicators rather than the ultimate outcome indicator. And I don't know if David has anything to add on that, because I don't know if you have developed another type of fracture calculator.
Yeah, I guess we haven't, and certainly point to the IOF standards and other things. Yeah, I don't think we have anything else to add. I mean, we certainly have case studies and other things up on the website, but nothing I would say quite specific. But definitely something that we've heard from others as well as a challenge of getting that.
It's a challenge. In the UK, it has been developed, and they are piloting it in the UK. But they have extremely good possibility to record what they're doing through certain programs.
Great. So the next question is, how can you achieve the aspirational, for example, a vertebral fracture?
I think the vertebral fracture one is going to come, because the discussions about the vertebral fractures and their neglect, the awareness of this is increasing. And when you have all the other parts in place, I think it's time to start with it. It's a difficult one to start with, because you need to have the logistics ready, so that the radiologist knows exactly where to send the report, and that the patient get information that they will be called for an additional investigation, because that's part of the logistics within this. But from what I hear, people are beginning, and again, it's one of those where you probably start in a smaller scale and develop it, upsize it.
Great. The next question is, what happens if I do not have an FLS? Can I still fill in the questionnaire?
No, you can't really. You have to have a system. The FLS builds on having a systematic approach to that, for certain that all the fracture patients are captured. And if you only see random patients that come through, it's not really fitting the FLS system or the best practice framework. We have places where smaller clinics are seeing many patients, then it fulfills the criteria, or may fulfill the criteria. Some do not.
Great. Our next question is there data on patient contact after the fracture and successive follow-up, either face-to-face or by phone? Many patients are not getting face-to-face contact, and we have to call them because they are either missed in the hospital or are not admitted after going to the ER with a fracture?
I'm not sure I fully understood the question, but let me take it this way, that some of the patients may not be seen in person immediately for an FLS, but many systems rely on sending out letters or automatic letters when we see that they have a fracture. And with that letter, there goes a questionnaire on the fracture, a quick questionnaire on risk factors, and an information that if they have a great enough number of risk factors, they will be called for further assessment. It's a way of making it more efficient and also use the resources for patients where it's most essential that they are used. And of course, everyone would like to be seen, but this is a way that I know quite a few systems are working today. I don't know if that answered the question or if I understood it completely.
Great. Okay, our next question is, what about educational influence in the hospital? Written materials showing to patients can be helpful with increasing fracture patient follow-up. So they're asking about educational materials in the hospital and when that could be most effective.
I think that overall the information on osteoporosis has increased tremendously over the past 10 to 15 years. Patients are a lot more aware than they used to be. We have, for example, at our hospital developed a web program with a slide set that is running continuously in the waiting room of the fracture clinic. That is a tool that helps us inform the patients when they're there. And it's a sort of an easy way to get some information. So I think it's shown that patient information is important, and we also see that schools, when you have osteoporosis school, improves the knowledge and improves the for adherence to the various interventions the patients are asked to do or receive. So I think those are some of the points. We also think that education, not only of patients but of staff, is important. At our hospital, we have initiated and created a program that all the staff, nurses and the nursing assistants and doctors have to go through on the web. And it ends up by firstly giving information, and secondly, they are assessed with the 5 simple questions, but if they make an error, they get a new question with a different answer. So we know that everyone has to have a certificate that they have passed the basic knowledge of osteoporosis.
Great. Our next question is, I am setting up an FLS in primary care and identifying patients from secondary care. We are different organizations, and at the moment, the block is around patient consent and sharing of information. Do you have any suggestions on how this can be managed?
Commonly, it's actually it is a collaborative effort, and commonly the primary care together with the close care or the emergency care has to agree on this in order to be effective. From my perspective, I don't see it as a problem about patient consent, but that's from my perspective. So we have systems in Sweden that are developed mainly from primary care, and it works well, but it has to be in close agreement with normally it's the orthopedic clinic who manage the patients rather than the emergency room. But I think that's unfortunately the only advice I can give.
Great, thank you. Well, it looks like we have time for one more question. Okay, which is better, face-to-face or by phone, in terms of success for follow-up with patients?
Quite a number of studies indicates that it's equally efficient to call the patient. Sometimes actually it's tedious and time-consuming for patients to go to the clinic. So follow-up by phone is regarded as equally advantageous, and there are quite a few studies showing that this is important. However, it may not be just one phone call after a month, but another phone call after 2 months and 3 months, and then the longer the patient has maintained therapy, the more likely they are to continue the therapy. So I think this is one of the more efficient ways of actually doing it, rather than calling patient back to the clinic on average.
Wonderful, thank you. I want to thank Kristina, as well as everyone, for joining us today for our webinar. As I mentioned, we will be sending up a follow-up that will include a link to the webinar video. And we will be having a survey that will pop up as soon as the webinar ends. If you could please take a moment and complete that, it would be appreciated. Thanks again to everyone.